On this week's episode of the Physio Foundations podcast, I'm talking to Associate Professor Michelle Hall about her research all about exercise for hip and knee osteoarthritis. Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So Associate Professor, it sounds good when I say it out loud. Associate Professor Michelle Hall is a good friend of mine. And when I last spoke to Michelle, or last hung out with Michelle, good 10 years ago when we were doing our PhDs together at the University of Melbourne, Michelle was not even a doctor yet. And she's done a lot in 10 years. And the podcast is my good excuse to catch up with people. And today I'm going to have a catch up with Michelle and find out what she's been doing over the last 10 years in the field of hip and knee osteoarthritis research and share it with you so you can have a research update as well. So these days, Michelle's based at the University of Sydney within Sydney Musculoskeletal Health and School of Health Sciences. And in some highlights of Michelle's career, and she can add to these, in 2016, Michelle completed the Global Clinical Scholars Research Training Program at Harvard Medical School. And now she has more than 90 peer-reviewed publications in the field of hip and knee osteoarthritis. She's contributed to clinical guidelines that we use to shape and guide our practice. And through a lot of hard work, we have to emphasise that, Michelle's attracted more than $5 million in Australian currency in research funding, including a project grant and an emerging leader grant from the Australian National Health and Medical Research Council. If you're not familiar with research and research funding and you haven't worked in research, these grants are almost impossible to get. And so Michelle's going to play this down in a minute and tell us that it's all luck, but it's not. It's actually really impressive. And it's something that she's a person that we should be listening to in terms of getting an update in this area. Michelle's received awards for research, including a Victorian Young Tall Poppy Award in 2019, another one that's really difficult to get and prestigious. So congratulations, Michelle. And she's an emerging world expert in the field of hip and knee osteoarthritis research. So I promised I'd embarrass you, Michelle. My great pleasure to have you on the podcast. Good to see you again. Michelle Hall, welcome to Physio Foundations.
Thanks so much, Luke. Thanks for having me on. And yes, I'm red. I'm embarrassed.
So very humble, and but also you've done a lot in the area, and I want to hear a bit more about it. But so tell everyone about you. Have I missed anything in my introduction? Anything else you'd add there?
No, I think that pretty much sums it up. It's really hard to believe that it's 10 years ago since we were acting having the crack in the back of the PhD room in Berkeley Street in Melbourne. Very fond memories of all of those times. They were good days, good times.
Oh yeah. When you're doing something like that, graduate research, when you're doing any difficult work, it's really important to have a good team of like-minded people that you can bounce ideas off. And yourself, Laura was on the last episode last week. A really good team of people that we did time together, didn't we?
We did. And I think it's such a good point that you make, is that some of the hardest things that you kind of do in your life, you look back and they end up being the some of the fondest memories. It really speaks to those people around you to make it that memorable, and it really, we really did have a great time.
It does really help. Tell us about your background. So what led you to do a PhD over 10 years ago now? And so who is Michelle? Who are you? What have you done before your PhD? What have you done since?
So I grew up in rural Ireland, so a small village in Drum, border county of Ireland, Northern Ireland. Very, very small. Grew up on a farm. My mum was a nurse, and actually didn't like the idea of being away from home very much. So I got into Dublin City University to do sports science. And the only reason why I didn't go on to be a maths teacher and a PE teacher was because I didn't want to go way too far from home down to University of Limerick, where I couldn't get home every weekend. So that's kind of ironic given where I am today. And I knew that I liked sports. I was really sports mad when I started exercise science. And then gradually through the course, I kind of got that appreciation about how exercise and well-being can help more people maybe than just your sort of elite few, the athletes. And I got the opportunity to do a research, like an internship, and I did that with a couple of friends over in London and Brunel University, and really loved it, and kind of got an insight to what life as an academic really was, because we worked really closely with the research team there. And so going back to Dublin, my mentor then, he was like, so what are you going to do? And I said, I really don't know, because I had these ideas. I didn't want to do health promotion. I really, like, goes, well, you've been going around like a Cheshire cat with doing the research project for your honours, so I think you should keep going. And he suggested that I go to America. And so I did my master's at Iowa State University in kinesiology, and was reading the papers from Melbourne, from Kim Bonnell and Adam Bryant around ACL injuries, knee injuries. And that was my passion, because my dad had knee osteoarthritis. And so I was really curious about how they were getting such big numbers for their trials, because I was trying to do a little cross-sectional study in Iowa State. I was trying to find 20 participants, and I was finding it hard. So I was curious, and I was also curious about randomized controlled trials, because I had got an introduction to them through my summer job on the plant pathology department, because I had to get work, within the university as part of the visa requirement. So I was kind of drawn to the research in Melbourne through that, and fortunately it sort of worked out that I could come and study with Kim Bonnell and the team at Chesham.
And so that idea originally was that you started off being sports mad, and then you're doing sports science, and you'd think the focus would be elite athletes and high performance, and then you very quickly discovered that a lot of the principles that you're learning about here could be applied to more general populations. And so, for example, people across the lifespan with conditions like osteoarthritis, and then you started reading all those papers and obviously doing your master's research. And a key word you've said that comes up again and again on this podcast was curiosity. You were curious about things, and that led to you traveling. So for someone who was really quite attached to your hometown and you didn't want to travel, you have traveled a lot. You've traveled to London and to America, to Australia, back to Ireland recently, and now you're back in Australia.
Yeah.
Very brave.
Well, it's so funny, like when you do look back, it was all really bit by bit. The first bit was going to Dublin and staying up there during the week and coming back home. And for 4 years, I did that. I came back home every weekend. I just didn't want to miss out. But during that 4-year degree, during the summers of that, I did a 1-month stint in Chicago. Turned out we had relatives of relatives kind of a thing. And it was kind of too good to miss. And so that gave me a taste of America and what it was like. But after that, I still was like, I could never do a big city. So that's why I kind of went to the smaller university towns in Iowa. But it was kind of like a gradual introduction. And I love traveling. I love the people that you meet, the stories that you hear. It's just, you can't make that stuff up. So it was kind of like a nexus of like traveling, which I became to really love and enjoy and studying. So it was kind of like the perfect storm for me to travel.
There will be some listeners who are doing their first degree, their undergraduate degree, and they may do future degrees, and they may be listening to this thinking, wow, I can't even imagine getting to the end of my degree, let alone all the things you can do. So with an exercise science degree, it's been so portable. You've traveled, you teach at the moment, you've researched in many different fields and areas. Obviously with an entry to practice physiotherapy degree or health professions degree, that's very portable as well. So hopefully when we do these intros to the episodes, we're sort of opening people's minds to all the things you can do as well. I could have jumped straight into questions about hip and knee osteoarthritis. There's other podcasts that do that very well. I always like to cover the origin stories of people. So other people listening can say, wow, if I wanted to follow in Michelle's footsteps, that's how you might do it. And like you said, bit by bit. You didn't do all of that in 1 year.
And if somebody had told me, like in first year Dublin, like one day you'll work in Sydney or be in Melbourne, I might have cried, but I would have certainly laughed. I would be like, that is so not me. Not no. So yeah, you never say never, but you never think too far ahead. You kind of go with the door that's open. But I think it's always really, really good to make yourself uncomfortable and be challenged. Because the last thing you want to do is sort of sit back in 10 years, look back 10 years and go, you want to be sitting somewhere different. I think you do want to be sitting somewhere different, whether it's in your personal life or professionally. But I think it's just pushing yourself and getting out of your comfort zone.
Yeah. Well, let's talk about research then. Hip and knee osteoarthritis. So over 90 papers. Obviously not all first author. Some are last author as the lead author. And some are your first author papers, for example, your PhD and postdoctoral research, and other papers that have been collaborations as a part of working with other people. So you'd be sort of in the middle author there.
Absolutely.
And people listening along, you can go to Google Scholar or ResearchGate and put Michelle Hall in there and bring up a list of these, and perhaps we'll talk through some of them now. What papers, or what areas, what research that you've been involved in do you think are the most impactful, or are you most interested in talking about today?
Yeah, so I have probably taken a little bit of a shift in my interests over the last maybe 12, 14 months, and a lot of it isn't published yet. The pile is getting, it's not out there. It's not out there yet. But so for a long time, we've known, or the clinical guidelines have advocated for exercise, right, to manage chronic hip pain, chronic knee pain consistent with osteoarthritis. And we know that, many people are satisfied with the outcomes in terms of they've got better function, they've less problems with their daily life, and they have less pain. But equally, I think it's really important for us to acknowledge that, there's a good proportion don't, right? And it seems so counterintuitive to somebody who's got a sore joint, where maybe they've seen an x-ray off their joint and they feel like, how can I be told to exercise when my joint looks like that and it's sore? And we also know that people who actually do the exercises and adhere to it don't actually do as well as we'd hoped, right? Now, this is notwithstanding all of the benefits that exercise and being physically active stand to us as we age and we grow older. And for me personally, I just strive to be an independent woman living in my hundreds, 90, and I'll do everything I can to hopefully make that happen. But one aspect that we've sort of overlooked a lot, and there's obviously body weight out there, studies, particularly at knee, where there's no evidence at the hip as yet around weight loss. Does weight loss actually improve hip osteoarthritis symptoms? And we're just about to close out a trial at the moment to answer that question. But over the last 12 months, I've become particularly interested in sleep. And I think this was really triggered by my 2-year-old son, who just decided to sleep through the night about a couple of months ago at 2. And the conversation I had with a colleague, David Klein at University of Queensland, about his animal studies and the really interesting observations that they were making about the role of sleep in this transition from an acute pain model that they were inducing in the animals to how disturbed sleep was facilitating this transition to chronic pain. And more so than that, it was when they allowed the animals in the cage access to a running wheel, how the physicality through being on the running wheel actually overturned the detrimental effects of poor sleep or disturbed sleep. So I tried to use this, when I wasn't sleeping great and I had my, the terrible boy, to get myself motivated to exercise, to override the bad night's sleep that I had, to keep that going. And then more and more, we had a student who was doing a qualitative synthesis of interviews with patients, and sleep kept coming up, like poor sleep. And it's not just that you have pain and people sleep poorly, but as I mentioned, there's more and more compelling evidence to say that sleep maybe drives this pain, intensity of pain, or the chronicity. So I sort of scoping out sleep more in the last 12 months or so.
That is interesting. Noah is 2 at the moment.
Noah is 2, yes. And I love him dearly.
I love how that story is, as a mum with a 2-year-old is waking you up. Suddenly became more interested in sleep.
Yeah, no kidding. Before this, I probably glossed over. Our first child, Faith, was like the dream child. Like, honestly, she slept like no dramas. And we were like, who is this boy?
We had that with Thomas and Henry. Yeah, Thomas was the nightmare, and Henry was the dream child.
Yeah. What's brave about that is that you went for number 2, and number 1 was the scary one.
Yeah, that's right. What's wrong with us? We weren't scared off. Yep.
Well done.
The first couple of years are really hard on parents, and then again, if you're doing it all on your own, it's a bit like we're talking about with the research, mentorship, and having a group of people you're working with.
Yeah.
When you're doing a grad research or PhD.
I do have memories, Luke, of you coming into the PhD room with squinty eyes.
Looking like I hadn't slept, and I hadn't.
You hadn't.
That's right.
I probably could never really empathize fully until I experienced it myself not that long ago.
Yeah, so. I was fine as long as there's no light. As long as there's no light at all, I would be fine. That's interesting. The rodent study you're talking about exercise offsetting some of the negative factors related to sleep, because certainly at that time I was doing a lot of ultra marathon training and running a lot, not compared to some of the elite ultra guys. I do 2 or 3 ultra marathons a year, and I was enjoying lots of long runs. And certainly if you looked at my sleep diary, this was before Strava and before watches were good and what they are now. It would look really bad if you were my coach. You would say, hey, you need more sleep, and probably would deload because of this, the impact of having young kids and you're doing your PhD and you're not recovering. But some of the best feeling subjectively I've ever had would be just sort of getting on with it and doing a big long run, and you'd be energized afterwards, even though you looked like hell.
Yeah. Yeah, and that's the inflammation, those neuromarkers that were measured definitely tell that story, and that how it's really quite remarkable. Neuromarkers, I mean, people float that word out a lot, and it's a lot of different biomarkers, and probably a different constellation for different people for different conditions. But I never saw the trace reversed so visually with exercise over disturbed sleep in these models.
It's interesting. Let's go back a step to your original research that you've done a lot of, which is biomechanical research of people walking and doing other functional tasks.
Yeah.
And let's give everyone a bit of a summary of some of the things you've found. So, for example, for your PhD findings with the knee, so you did, as a summary, you did you looked at a range of exercises to see if people can change their walking. Tell us a bit about that and what you found, because it's quite interesting.
Yeah. So for a long time, we've appreciated that higher loads during walking were associated with structural changes at the knee. So for quite a number of years, interventions have targeted, whether it's shoes or exercise, to reduce that load across particularly the inside compartment of the knee. But what's been really interesting, and my study included, is that there's so little evidence to say that some of these things can be changed with these interventions. So when we actually run very sophisticated biomechanical models, and I'm sure Laura spoke about them in your last episode, we saw no change in loads in response to exercise. And you might say, okay, well, maybe the exercise program wasn't specific enough, that whole realm around specificity. But then when you also look at shoes, or we've also looked at knee braces, it's called the unloader knee brace, we actually don't see very strong signals of these devices or interventions offloading the inside of the knee. So,
and just to go back a step, the mechanism that or the hypothesis is that so the load on the inside of the knee being the medial the medial tibiofemoral joint, and that's normal when you're standing on one leg. Your center of gravity moves laterally, and then it produces the knee. If we refer to it externally as a adduction moment, external knee adduction moment. In other words, the forces of gravity are trying to adduct the knee and cause increased compressive forces in the medial tibiofemoral joint. And then if you think that too much load is a bad thing and it might wear out cartilage with the simplistic view on that, you might think, well, that might contribute to the onset or progression of osteoarthritis. And then a lot of what you were doing was trying to improve people's strength around their hip and their muscles and their alignment through their shoes and even bracing of their knee to try to reduce that force
Correct.
And what you found was that you didn't change that force
That's right.
in walking or in other tasks.
In walking, we didn't change it.
Well, yeah, which is surprising, wasn't it?
It was surprising, but again, it was maybe that criticism around specificity. Maybe a gait retraining approach is more suitable. But yeah, as I said, we tried with the braces. So one of I'd say the advances over the last 10 years from when we were doing our PhD, we really focused and you as well, like we did external biomechanics. But the challenge with external biomechanics, it doesn't account for the muscle forces. And we know that the muscle forces are the greatest contribution of force across the joint. So we've been working with the folks at Griffith Uni to advance the models that we would now start to account for muscle forces, because we know that muscle activations are impacted by these conditions of the knee and hip. So we thought maybe it was our measures, right? So we went back and tried to work with leaders in the field to improve our measures. But again, we found no signals in the data that exercise, like consistent with the GLAD program, maybe people are familiar with the GLAD program, didn't actually change the load across the knee joint. But I think it's what's really important to be aware of when you do read this literature and, hear people speak about this, is that there's a huge differentiation between what people feel and then what we also go for, the structure of the joint. So there's kind of two endpoints in osteoarthritis research: is how people feel, and that's the patient report outcomes. And then a lot of it is around the structure of the joint. And yes, the FDA and the states will approve it if it modifies the structure of the joint. There's a lot of research going on around that. But I think it's so important for people to remember what your joint looks like is not representative of how a lot of people feel.
And so you can, and what Laura was talking about is you can change symptoms through modification, through strategies.
Right.
You go back 10 years ago, and what you were finding there was based on 10-year-old assumptions that, okay, well, we change loading and maybe that will help change structure and that may in turn improve symptoms in time, but it's not how it worked.
No, it's not. And this is where we kind of reevaluate where the pain symptoms come from. Where is it actually coming from, the joint, or is it maybe more central sensitization, inflammatory? And then I suppose that's where the sleep theory kind of comes into that as well. I think, yeah, structure is one part of it. Of course, we want to preserve and maintain a healthy integrity of this joint, but it doesn't always correlate to how people feel.
So if we were explaining to someone, say a student, health professional student or a patient, how does exercise help with osteoarthritis? The older explanation would be something related to loading and cartilage health and those things that we can measure. But as you just said, it's multifactorial. There's a person attached to the knee and the hip as well.
Yeah.
With a mind and a brain.
Right. With so many things going on. I think by the exercise helps by improving somebody's self-efficacy. We know that muscle strength improves function, and function is a big problem with osteoarthritis. So, I think the expectation is that, yes, you're going to get some relief from this, and hopefully it's enough that you're satisfied, but it's keeping it real, and it's like how you manage it on a day-to-day basis. And I appreciate that it will vary, and everybody will experience a flare probably at some point, but it will normally pass.
I think that's a part of the range of osteoarthritis programs that exist. Is always that education and talking about the fact that it varies, and you have flare-ups and how to manage flare-ups.
Right.
And that's a part of every good clinician I've ever spoken to will talk to people about the realities of flare-ups and managing them. So it was interesting how you started this conversation with talking about the people for whom exercise isn't as effective. And there's a lot of barriers to starting exercise for someone who's had all the nocibic language and has the first thing they've read is that MRI report that's filled up with terrible descriptions of things, and you need to work against this tide of negativity in order to get them to think, well, actually, load and movement is good for many things. You've listed them: self-efficacy and function and pain management and obviously being a part of the world. You need to move and do things. And but it's kind of difficult when people are have this idea that pain is going to be caused by structural damage, and they've seen it on an MRI and they've read the report.
It's very, very, very tough. It's very, very tough, and I think it takes a really skilled clinician to overcome anything that somebody's read in Dr. Google, or unfortunately may have heard from another healthcare professional. But I think there's a global, I think, last year or this year, they came out with the global kind of call to action, a narrative to change the narrative of how osteoarthritis is described. Because we do know one of our PhD students, Travis Haybar, really talented guy, just submitted his PhD this week, and definitely one to watch. He really nicely showed in an online RCT the detrimental effects of the description of how you label or describe a diagnosis. He had a very old school, a bit more contemporary. And it was really, really interesting because people were less satisfied with the contemporary that wasn't concrete, maybe wasn't more like physical, biomechanical. But having said that, they indicated that their intention to exercise was less when you gave the old-fashioned one, and their belief that they needed surgery was greater with the old-fashioned versus the contemporary. So it's somewhere in the middle where obviously we need people more satisfied with the label and the explanation of what they have. But we know that, if exercise is the first-line treatment, we should not be saying exactly what they say on an X-ray or an MRI. It's just so not helpful to get people to do the first-line treatment.
And Travis's work, you can find that on ResearchGate or Google Scholar, and you can have a look at those papers. It's excellent.
On JOST. He published that one in JOST.
I can really see it from the person's perspective with hip or knee osteoarthritis, and having the reports that come in, and going to Dr. Google and reading the things, and then I can really see it from their perspective. And so I think you said that nicely in terms of how you pitch it. You do need to be somewhere in the middle. There are structural changes that occur, and there are changes to pain sensitivity and your function and your physical activity and a range of things that you need to work on. I think it's just a matter of being honest with the person as well, and investing in them and working with them over time.
Yeah, and I think it's that expectation is that, just because we see this, it doesn't not mean to say that you will have to have a joint replacement. Lots of people function very well without. It's not your inevitable endpoint.
But certainly delaying it if it is going to happen to a later time after retirement, and when there's less heavy loading. And my mum's had 2 knees replaced since we last chatted. And they're going very well.
Very good.
The students have enjoyed little case studies that have come out of it during the pre and surgery and afterwards.
Very good. I
don't know if they've enjoyed them. They've certainly they've had them. It's a real story, but that's such a common surgery that they'll have to work with people.
Absolutely.
So
absolutely.
Might as well share it.
Absolutely.
So this is really, really important conversation here, because you're one of the researchers who is leading in this space, and you've really been active as a researcher in this really crucial time where we've gone from the early days of your master's research. It was very biomechanical and biomedical dominated, the research in this space, and it's big. You've talked already about the importance of sleep and psychological factors, and of course function, and so we're going more in that direction. What else? What other highlights, or what other important papers have you published? I know that you've been involved with clinical guidelines as well. Tell us more.
Well, some of the work that we did during a PhD was picked up by some of the guidelines over in the States to manage meniscal tears, and it was essentially just to say that neuromuscular exercise was another option, or is another option, to manage people with musculoskeletal, arthroscopic partial meniscectomies. So I'm going to be involved now in the ORSI clinical guidelines, so we're just about to convene on that. So I'm not going to lie, it's a whole new learning space for me, but it's basically a bunch of systematic reviews on different interventions, But it's an interesting space at the moment because clinical guidelines, we often have to wait, maybe 5 years for every, let's say, body or authority to come out and update them. But there's these things called living clinical guidelines or living systematic reviews now that can maybe be automatically updated as relevant clinical trials come out. So we don't have to keep waiting each time for an iteration.
Yeah, that's makes so much more sense.
Definitely learning in that space, but also the appreciation, that clinical guidelines they're guidelines. They're not that helpful when you're with the patient in front, and so much of that clinical intuition and clinical expertise was still going to be very much on the clinician. We can write in black and white text what you should do for this scenario and that scenario, but it's never going to be all encompassing of every scenario.
It's in the name, isn't it? It's you take your guidance in terms of aligning what you're doing generally with the evidence, and then that's important for insurers and for third parties to look at what you do, and it's really important to be evidence based, but certainly not a rule book.
No,
recipe book.
No.
And so sorry, go on.
Oh no, I was just going to say, I think maybe it's more like a rule book of maybe what not to do. It's like to prevent harm, like that kind of a way. But then I think, and there was an interesting discussion at ORSI amongst the committee, it was like, we're really not leaving researchers clinicians with very many options if we start being really tough on the quality of the research that's being out there. So it is a bit of a tension, but yeah, that's probably.
Yeah, that's really interesting. So, contribution to guidelines, publishing lots of papers. Give me a couple more dot points on some things that physio students and clinicians can take away from your research. I'm just leaving this very open.
Yeah. Oh, look,
I know you and I have had lots of good chats over the years of lots of different topics. So.
Yeah. Well, look, I'm going to bring it back to sleep because it's been quite on my work plate these days. Trying to develop grants. I think what's so interesting is that sleep is rarely managed as part of somebody's musculoskeletal complaint. A clinician, a physio might ask about how somebody's sleeping, but they probably don't have the tools to address that.
What sort of tools could a health professional, say a physio, use as a part of their screening or management or referral?
Yeah, so there is really nice work done by a couple of trialists in the States that cognitive behavioral therapy for insomnia is effective to reduce pain in musculoskeletal conditions. So, whether and there are cognitive behavioral therapy for insomnia apps out there. There's definitely some in Australia. There's some endorsed by the Department of Veteran Affairs in the States. So maybe guiding people towards that, those apps, if they feel like it's appropriate. And there's the insomnia severity index that can kind of give a clinician idea of where somebody is in that insomnia scale, and that might benefit from something like cognitive behavioral therapy. But one of the research streams that we're looking at the moment is to maybe upskill some physiotherapists. Not like you don't have enough to do, but in your practice, but for those who would be interested in providing sleep support for insomnia, that may be able to walk participants through this. So it's like a 6-week intervention over 6 consults over 8 weeks. So it's not terribly invasive, like time intensive. But the benefits on sleep can last out to over a year. So it's quite behavioral, like it's about sleep hygiene and I'm not a psychologist that developed these things, but certainly it sounds like quite an attractive tool perhaps for physios to consider.
There are a lot of threats to sleep and sleep quality in the modern world, that obvious ones that everyone's got in their pocket right now, and often get put on the bedside table and brought to the bedroom with us. So there's lots of distractions and interruptions to sleep, and Netflix accounts and Disney Plus and everything else that we now need, need. But maybe, like you said, the average practitioner has a lot on their plate. They don't need to be an expert in everything. Right. But if you're at least aware and you can start a conversation, if someone already is wearing a smartwatch and they're monitoring their sleep, and my back pain or my knee pain is now affecting my sleep, that's usually a cut point where you say, okay, if it's affecting your sleep, it's affecting your work and your quality of life, but you're functioning okay, but it's affecting those things. That things can spiral out of control, and that can sort of lead back to your through your pain processing and everything, and make the pain worse. So just directing people towards that information could be a really good starting point, particularly if you're the first person someone's seen.
Right, exactly.
They may not have even seen their doctor.
Exactly.
I think I'm always a fan of suggesting to our students and our grads to say, if in doubt, get the person to do a checkup with their doctor.
Yeah.
Always go back and check up, because there may be things that you've missed as well, but
Absolutely.
directing them towards some measurement through the app or through their phone and having that conversation.
Yeah.
Starting point.
Yes, I think so. And I think that what's amazing for me when I talk to clinicians, the psychologists, about cognitive behavioral therapy for insomnia, because we had some consumer input, like patients input, and they're like, that's never going to work for me because I wake up because of my pain. I don't have a problem getting sleep, but it's my pain causing my poor sleep. Whereas I guess this line of inquiry is more around the role of sleep in the pain, if that makes sense, so like a bi-directional relationship. But the psychologists assure us that they have seen improvements and they've got the data to show it, that, learning the sleep techniques and no phone, when you do wake up, you get out of the bed, you don't lie in the bed with your phone, you get up, you only are in bed because you sleep, etc. We've got these different techniques to train the person to sleep in the bed, to only be in the bed while they sleep. So it's not just for the people who wake up because they're in pain, but it's actually for that general person who's come in with quite severe pain and who sleeps poorly. It's something that can be considered as part of their management.
And as you said earlier, when you exercise, that quality of your sleep improves. And who hasn't felt that nice deep sleep after an exercise or some sort of a game or training or an exercise or run or whatever you've done? So if it's sometimes when you have a chronic musculoskeletal condition, it's quite difficult to get back into the physical activity as well, and then that can feed back into poor sleep.
Exactly. And it's not just about sleeping better, but you kind of subconsciously know that your immune system is responding better when you have that bout of exercise. You do that, be physically active, and it would override the detriments of maybe a bad night's sleep.
And these are really good education points for our patients. You don't have to be an expert in things.
No, it's just an awareness. It's just awareness. And sleep was raised as a priority of the Australian government last year because it's costing the economy an absolute bomb. And I think it's like 14 billion, and it's like productivity is a huge driver of that. And, I'm only talking about a subsection of that sleep within, but I think we can all relate to it. We've all experienced a bad night's sleep. And I think what's nice about talking about sleep with people is that there's quite a lot of attraction. People want to sleep better. It's easier to get to people to want to do it as opposed to like changing your diet and changing your exercise. It's challenging for some people.
And sleep's really a scheduling thing, isn't it? It's something that you plan.
Right.
You plan to do it. When you wake up and you have had a poor night's sleep, the first thing you think of is, I'm going to get through today and I'm going to go to bed early.
Yes.
The first thing I think of. You think about getting back to bed. And then there's lots of threats to sleep from distractions in various work and stress and everything. But even if people are just aware that it's less of an option and more of an important part of your recovery. I think athletes because you're an exercise scientist by primary training, I mean, in the sports science world, people are very aware of using sleep for recovery and the importance of it. They've got all the biohacking and the various 1%ers and the ice baths and things. Everyone loves that stuff. But, if you get a good night's sleep, it trumps all of that.
Right. Absolutely.
But I'm less aware of all the research you're doing and the with research in the chronic pain and chronic musculoskeletal health space. It does make a lot of sense.
Yeah, I think the other interesting part to this is that, so you can kind of like design interventions or physio can treat a knee pain in a certain way or hip pain in a certain way. And we start to appreciate that there are differences between the two presentations. But maybe something like sleep is kind of doesn't matter whether it's hip pain or back pain. And so we're starting to look at, or explore, I should say, probably more is the better, different types of studies that you could do, that you don't have to do a trial for each joint to come up with an answer whether targeting sleep is better than, or can we take some adaptations of designs from oncology, for example, that are way ahead of the game in this space in terms of trial design, and to see if we can then borrow some of their approaches in musculoskeletal conditions, so we can answer an important question for more people.
That's really interesting. Well, let's change direction slightly. So you're on your bio, on your University of Sydney bio, one of the points that I haven't covered yet is you're an advocate for women and girls in STEM, science, technology, engineering, mathematics, and you've obviously gone a long way in that field yourself, and you pioneered, which will be it's going to be the title of this episode. Associate Professor Michelle Hall, pioneering hip and knee osteoarthritis research. You certainly have done that. And so what are some of the challenges that women and girls face in pursuing careers in STEM fields, do you think?
Yeah, it was such an interesting topic, and I just kind of got into this, I wouldn't say by accident, but it wasn't like I set out. It was never like I had heard such a terrible experience, I got to change the world about this. It was never like that. And I never actually, I'm pretty naive, to be honest. I don't look up as much as I should and see what's around me and what other people experience. But I got involved as a mentor for high school students through a group called BrainSTEM. And it's the guy's based down in Melbourne, Sid Verma, and honestly, it's an amazing program that reaches students across high schools and pairs them up with a mentor within a university or academics or an industry setting, and they mentor them over a 12-week period. And it was such a fun experience. But as part of that work, we went into the Australian New Zealand Biomechanics Society ECR retreat. And I can't remember, were you on? I don't think you were on that, but that was like a couple of years ago. But you did this collection of people with extremely different interests. Like there's one like on dinosaurs, there's another one on musculoskeletal strength. Like, I mean, very, very broad research interests, veterans, military, etc. But we all like wanted to work together on something. And Celeste Coleman from Canberra University had then subsequently came across this idea of doing something women in STEM. And so we kind of used the BrainSTEM model and to brought it in and created this thing called Brink. And it's honestly probably one of the most enjoyable experiences I've had on a project, where you kind of got 8 girls and 1 guy kind of delivering this national program that was tuned in for biomechanics, and it was targeted at girls because girls are, the narrative is that girls are less well represented, unfortunately, in lots of different spheres. And we've started to explore the barriers to that. And it's kind of because they don't have role models, and they don't have confidence. They think they can't do it, or, the boys are better, that kind of thinking. So, it was kind of an opportunity to give back, but also to hear firsthand the impact of things that you kind of maybe don't think anything of, how you can help somebody. It became really, really powerful. And yeah, it's such a nice group of investigators that got involved in that. It was, as I say, one of the most enjoyable projects I've been part of, and we're in our 3rd year now.
Okay, wow. Yeah, so there's the importance of having a role model. We can't be understated.
Right.
You can see that someone else has done this.
Yes.
That's really interesting. So you'll continue with BrainSTEM?
Yeah, so I continue with BrainSTEM. I actually got my first opportunity to be on the board of directors. So that's been a totally new experience to see how that's run. And I met really wonderful people in the business sector that, I get about 20% of what they say, because it's a great opportunity, to throw you. And that's one of those things I was like, Sid, I don't like you think. And he's like, no, you come out, you know exactly what we're about. So that confidence and that reassurance from him. So I do that, and then I also mentor in the Brink program as a biomechanics. And actually, 1:15, I am jumping off this and doing that session with a Sydney school this afternoon.
Okay, well, it's 1:04 p.m. at the moment, so that is our cue there to wrap this episode up. That's really, really important. The importance of mentoring. We've talked about on this podcast at length, but I think that was an important point you made. The importance of having a role model there. So that's something we can come back to in part 2 when we do this again.
I think the thing is, never underestimate how you do what you do influences somebody else. Whether it's above you or below you or at the same level as you. And remember that none of us are there, but none of us got anywhere where we are by ourselves, So it's good to share the love.
That is important to remember, because sometimes when you, especially in your undergraduate studies, for example, it is all about you. You've got individual grades and marks and you're training yourself up. Yes, you're doing it alongside others, but when you work in your career, everything's in a team. And, you definitely don't have to do it on your own. That's a good final thought. Any other final thoughts before we wrap our fireside conversation up? That's the format of the podcast, fireside conversations.
No, it's just a reality ching-ching of the whiskey glasses. Thanks so much for having me on.
And it's a shame to do it on Zoom. We'll have to do it in person, but next time we're in the same city, we'll catch up again. But yeah, really good to see you again, Michelle, and great to hear about all the things you've been doing. Congratulations on all your achievements. And you're very humble. You're going to say, oh, it's all luck and everything, but it's not. It's a lot of hard work. And you are a role model for the next generation, particularly girls, but all sorts of girls and women in STEM, but all sorts of people are going to look at your pathway and go, hey, I could do that as well.
I can only just say really for sure, if I can do it, anyone can do it. Because I'm telling you, it's
you might be good at this stuff.
It's but if anybody ever wants to reach out and chat or ask about anything that we talked about today, never be shy to reach out to people and never get too worried if you don't hear a response. Never sit on your fingers, so to speak, and not write that email to reach out to somebody.
People can find your email on the University of Sydney site and on social media. What's your tag again? I'm off Twitter because I messed up with my password. That's a long story, but I'm on LinkedIn. Twitter or X won't let me back in. Okay. Oh, well, that's a write-off. But you can look up Michelle on her bio, on her website, and get in contact through there or through LinkedIn. But thanks again, Michelle. Really appreciate it.
No worries, Luke. Thanks so much for having me. Take care of yourself.
Yeah, you too. So until next time, this is Michelle and Luke wishing you all the very best with your studying, professional development, and lifelong learning.